Hello and welcome to the weekly Independent Sage briefing. The government recently announced its COVID autumn-winter plan for 2021. That includes measures to try and curb the spread of coronavirus later this year, such as enhanced vaccination programs with jabs available to people 12 to 15 years old, and also boosters for those over 50 and certain vulnerable populations. Now, while this plan's welcome, Independent Sage believes it doesn't go far enough, either to mitigate the spread of COVID or to provide support to those who need it. So that's why Independent Sage has written its own winter plan. That's been published on its website and will be the focus of today's discussion. Professor Stephen Riker will shortly present the plan. But before he does, we're going to go to Professor Christina Pagel, who will present the latest COVID figures. Christina, over to you.
Thank you. Oh, pressed the wrong button there. Right, so today's numbers, so I'll be doing it in this order, starting off with vaccinations, then cases, then hospitalizations and deaths, and just end on children and the international picture, particularly around children. So vaccination data still going on. Scotland and Wales have now got 70% of the total population fully vaccinated, which is really good news. And England and Northern Ireland are not that far behind. There aren't that many people on one dose now, so it's kind of either you're fully vaccinated or not. And hopefully this will start shifting now that we're vaccinating over 12s as well. This is what the coverage looks like by age. This is for England. So you can see really high second dose coverage, over 90%, often 95% in the over 50s. It starts going down a bit with age, but we are still getting, reasonable take up here. And in the 16 to 17-year-olds, we've got almost 60% of 16 and 17-year-olds now have had one dose, which is actually really high. And hopefully over the coming weeks, we'll start seeing data on 12 to 15-year-olds, but also booster shots. Now, one thing that hasn't changed over the last 6 months is differential uptake here's by deprivation. This is the second dose coverage by deprivation for England to the 31st of August. This is all over 18s. And you can see there's quite a big difference, almost 20% difference between people living in the most deprived communities and living in the least deprived communities. And this matters. If we're going to be kind of living with a high level of COVID, it means it will be disproportionately affecting unvaccinated populations in more deprived communities. And again, we see a similar pattern by ethnicity. This is second dose coverage, also everybody over 18 in England to 31st of August. And again, you've got 80% of the white population fully vaccinated compared to less than 50% of the Black British population. So again, that is quite a big discrepancy, and it's something that we haven't managed to really fix over the last 6 months. And I think, again, as the pandemic is moving into kind of a pandemic of unvaccinated, that's where the really severe outcomes are. This matters. And I just wanted to say a couple of things about the case for boosters. So JCVI have recommended booster shots to everybody over 50, the original 9 priority groups starting this month. And I just wanted to kind of highlight the evidence behind this. This is from a Public Health England report where they looked very carefully at waning of efficacy of the vaccines against infection, hospitalization and death in different age groups. And this is analysis from that report done by the Financial Times, which has really nice graphs. So this is showing effectiveness against symptomatic infection. So kind of just getting COVID and feeling sick from COVID over time. So this is weeks since your second dose. And you can see that for both Pfizer and AstraZeneca, protection against infection does go down the longer it is since your second dose. And overall, Pfizer gives you better protection than AstraZeneca. But it does kind of matter what age you are. So people over 65, it's quite a strong effect, and it's a much, much lower effect in people aged between 40 and 64. So that's kind of one really important thing, and also why I imagine they're not going to be boosting under 50s anytime soon. Just also what came out of this report, nothing really to do with boosters, but I think it is quite interesting when you're looking at the UK compared to the rest of the world, is that this is for over 80s, people who at the very beginning got Pfizer 3 weeks apart compared to everyone else who got it at least 8 weeks apart. And you can see that the longer dose interval does seem to be associated with higher efficacy against infection. And so I do think actually that decision by JCVI back in January has really paid off. And this is just like the final plot on boosters. This is looking at waning by your age, but also by whether you have an underlying health condition that makes you vulnerable. So the first thing here is that if you're over 65 and clinically extremely vulnerable, so in the shielding category, there is quite a big waning effect. And I think there is quite a clear case here for boosting these people. If you're over 65, but not clinically extremely vulnerable, there's actually not that much waning for Pfizer and more waning by AstraZeneca. If you're 40 to 64 and you have an underlying health condition, so this is kind of people who would have been in group 6 in the original priority list, there isn't that much data on Pfizer out past 20 weeks, but for AstraZeneca, it does seem as if there is some waning after about 20 weeks. But if you're not in a clinical risk group and you're 40 to 64, there's no waning. This is against hospitalizations, this is against severe disease. And so really it's showing that for that population, so for kind of healthy middle-aged people, the vaccines are working really, really well 5 months plus. So I think that's certainly partly why they're saying you don't really need anything for the first 6 months. And then let's start prioritizing people who are extremely vulnerable and a bit older. So just moving on to cases. And before I show the case data itself, I just want to show the data on tests, because obviously it does matter kind of how many people are getting tested. So this is the number of tests done every day by whether they're the rapid test, the lateral flow tests, or PCR tests, which are meant for symptomatic people in England. And PCR tests have stayed relatively stable. They increased when we had that big July peak and kind of went down a bit over the summer and are going up a bit now. The lateral flow tests are really jumpy. And this is kind of the return to school in March. This is the return to school in April. This was kind of the rise of Delta in July, where a lot of children were getting it and presumably encouraged testing. And this is the September school return here. But you can see since then, the number of lateral flow tests recorded has gone down again. So what we don't know is whether people are doing lateral flow tests and just not recording the results, particularly if they're negative. So it's a bit kind of unclear about what this means, but it just means be aware that there is kind of differential behavior in who's getting tested. And you can see that particularly in schools, because, you know, in theory, all students are meant to test themselves twice a week. When people return to school, there's often a concerted effort by the school to get people tested in the school. So you have high compliance, which is what you see here and here. And then once people shift to doing tests in their own time, it drops down. So you can see a big drop between the first and second weeks of school here. And that drop is entirely in students. So the staff numbers to getting tested is the same, but it's students that are dropping. And we saw from before, which goes up to a bit longer, that is continuing to drop. So it doesn't look like there is that much lateral flow testing going on in schools. Right, so this is the case numbers. Up to yesterday, over the whole of UK, you can see this kind of increase over August, then it dropped a bit, and now it is clearly going up again. And I kind of showed this 2 weeks ago. I'm just showing it again to show you, that this wave is going on a long time. It doesn't look like it's going to come down very quickly, partly because, you know, we're not really mitigating against it. So we've had, you know, 3.2 million confirmed cases since the middle of May, when Delta became dominant. And this whole period from September to March, we had 3.8 million confirmed cases. And at the moment, we're adding about 230,000 cases a week. And so if that keeps going, in a few weeks, we'll have had more cases in this wave than we had over this whole period here. Now, as we'll see, that isn't translating to anywhere near the same number of people being admitted to hospital or dying, but it is still quite a high burden of disease, and many of these people will go on to develop long COVID, unfortunately. So by nation, it's quite different patterns. These last 3 points are quite recent days, and so they will have more cases added to them over the coming days, but I wanted to put them in because you can see that even though they're incomplete, you're already seeing upticks in England and Northern Ireland and Wales. Scotland has been reducing for several weeks, and that's continuing. The positivity data shows kind of a similar pattern, but kind of only goes up to about here at the moment. So it's showing declines in Scotland, Northern Ireland, and England. ONS data released today, which tests people randomly and just tests to see, are they currently testing positive? So it's a slightly different measure to a new case, is completely consistent with what we're seeing in the case data. England has been high and flat all summer, slightly going down. Northern Ireland also high, coming down a little bit. Wales is going up. And Scotland, they're showing, is still high and flat. But remember, because ONS is testing if you test positive right now, it kind of takes longer to drop than the new case measure does, typically about a week or two later. So we should start to see the Scottish data dropping next week or the week after. This is where cases are. So they're still higher in all of the home nations than they are in England, in Wales, Northern Ireland, and Scotland. Within England, higher in the north and the Midlands again. And just looking regionally here in England, I just want to show you that you can see all the regions are going up except London, as it happens. But there's quite a clear difference. This is the northern regions and the Midlands, and this is the southern regions, and you can see that once again, the burden of COVID is being felt disproportionately in the north. So, hospitalizations and deaths. This is comparing the number of people in hospital across the nations. The good news is that that's coming down in England and Northern Ireland. And last time we could see really rapid increases in Scotland and Wales. That is now leveling off and looks like it might just be starting to come down again, which is really good news. Looking at England in particular, admissions are dropping. I imagine partly in response to the overall drop in cases recently. They've only just started going up again, but also, as we'll see later, cases in older people in England have been falling for the last few weeks, and they're continuing to fall, and that will be impacting hospital admissions, which is a good thing. Now, the last few days are missing. It's not quite clear why. They said there was a kind of data issue, so we don't quite know what's been happening over the last few days. And in Scotland, where the most recent really high wave ended up with a lot of admissions that weren't that far off their January peak, admissions are dropping quite rapidly now, which is really good news. In terms of deaths, really, the high levels of COVID that we've seen over the summer are continuing to result in people dying. So we are averaging over 140 deaths a day now. It's been high for several months, as you can see, even if it's nowhere near here. So since the 1st of July, we've had over 7,500 deaths from COVID, and the ONS data says that 87% of people with COVID on death certificate died because of COVID. They're not dying with COVID, they're dying from COVID. Over the same period last summer, so 1st of July to about now, 2020, almost 1,500 people died. So you can see that we've had a lot more deaths this summer than we did last summer, which I think, to be honest, in an age where we've had most people vaccinated, is not particularly a good health policy. So moving on to children. Last time we looked at Scotland, this is just checking in on where Scotland is. This is confirmed cases in under 15-year-olds in Scotland per day from the 1st of July to the 20th of September. And you can see that this is the massive spike that they had in Scotland when children returned to school. And although, yes, they were testing regularly, they were also testing regularly in the summer, and you can see there's no comparison. Since the 17th of August, there have been over 43,000 cases confirmed in children in Scotland. That's 5% of all under 15s in Scotland. Confirmed case over the last 4 weeks. And that's more than in the entire year before that. And that did translate into really increased hospital admissions in under 18s in Scotland per week. But as the cases have come down, that is now starting to fall, which is good news, but it's not that none of those infections mattered. Some of those infections did lead to children being sick enough to need hospital. But what we are seeing is potentially that those really high infections in school-aged children did feed through to their parents' generation. So hospital admissions in 30 to 49-year-olds in Scotland are higher now than they've ever been throughout the pandemic. So you can see that here, just starting to level off maybe. And this is in a generation where 3/4 of 30-somethings and 86% of 40-somethings are double vaccinated. So you can see that actually if you do have really high infections going around, it can still result in a lot of people getting sick and actually getting quite severely sick. And although hospitalizations have been going up in other adult groups, it's only in this group that they're higher than they've ever been. Just carrying on for the home nations, if we look at case rates in Wales by age, you can see a similar pattern where since schools went back, really, really high increase in 0 to 16-year-olds, very dramatic drop off in 17 to 24-year-olds. And we're seeing that across the home nations, we're seeing that across the world. And I think this really is the impact of vaccinations in young people kicking in. They're very, very effective in young adults, but also, unfortunately, high cases over the summer is also adding on a bit of natural immunity to that as well. But really what you're seeing is that children are the group where cases are really going through the roof and all other age groups are falling. In Northern Ireland, again, a very similar picture. This is 5 to 14-year-olds. So you can see climbed very, very steeply. The most recent week that has fallen, but is still extremely high, almost 1,000 per 100,000 per week. So that's 1% getting affected in a week, compared to adults, which are dropping quite steeply. And again, it's the same picture in England. This is a graph of cases that the FT did this week. This is 5 to 14-year-olds. This is a return to school. And again, you're seeing that the other age groups are dropping. Now, there is very recent signs that 15 to 19-year-olds are going up again. And it'll be interesting to see what happens, because next week is Freshers' Week when a lot of people are going to university. And very early signs that potentially cases in 5 to 14-year-olds is now feeding into their parental generation, as we might have seen in Scotland as well. And just looking at sheer numbers, so the whole of the summer term this year, so from 19th of April to 23rd of July, there were 172,000 cases in 5 to 14-year-olds that were confirmed. And since the 1st of September, so in the last 3 weeks, we've had 103,000 cases already in 5 to 14-year-olds. So we're kind of seeing that a lot of children are getting affected at the moment. If we look at hospital admissions in England, what is good news is that these are coming down in under 18s. So far, the surge going back to school has not translated into hospital admissions, although, as I said, the last few days are missing data. Now, part of that could be that there was a slight drop a couple of weeks ago. Part of it also could be the impact of 16 or 17-year-olds getting vaccinated. And I just want to talk about long COVID and another reason why high infections in children matter. So there's been a lot of kind of controversy about how common long COVID is in children. And there are lots of different studies now trying to look at it. The problem is that they give you very different estimates. And that's because they do different things. They have different lists of symptoms as to, they ask you what symptoms do you still have? And the fewer symptoms you ask people about, the lower rates of long COVID you find. And we know that it can present up to 200 different symptoms. We know that people, looking at different durations, is it 4 weeks of symptoms, 5 weeks, 12 weeks, 15 weeks, that matters. They have different ways of finding out if you had COVID to begin with. Some studies rely on you saying, I had COVID. which particularly matters when you look to the first wave when people weren't getting tested. And some say, okay, well, you have to have had a positive test. And some say, okay, well, you have to have antibodies against COVID. And that changes your estimates. They're looking at different people. So some surveys will, for instance, miss people in more deprived areas or people from ethnic minorities where we know long COVID is more common. We also know that one of the characteristics of long COVID is that it can go away and come back, go away and come back. And different studies have different ways of dealing with it. So some will say, okay, well, you're allowed to have a week gap or 2 weeks gap of symptoms. Some say, no, any gap means it's over. And again, that changes how you do it. And then, some have a control group, and then all of them really rely on parents reporting for their children, which can be problematic as well. So in the UK, there are 4 relatively large studies, and all have kind of estimates of persisting symptoms for at least 12 weeks in children. And they all have quite different ones. But basically, they range from about 2% up to 14%, and then things in between. The largest study is this CLOCK study, which is specifically aiming to look at long COVID in children. So, for every 100,000 children affected, which is, remember, is about how many people have been affected in the last 3 weeks, anywhere from maybe 2,000 to 14,000 children might end up with long COVID. So there are consequences to that. And even if you have a short-term illness or you have COVID that lasts for maybe 10, 12 weeks and then goes away, if that affects concentration or memory or fatigue, it could have negative impact on education and school-age kids. So for instance, the CLOCK study at 12 weeks said that 6% of children who tested positive for COVID reported ongoing confusion or drowsiness, compared to only 3% with negative tests. And it was higher in the acute phase of the illness in the first 2 weeks. So there are implications for your education. And finally, I just want to look at, well, it's not finally, but almost finally, vaccination impacts in children in England. This is from Public Health England, looking at case rates by actual year group in school. This is secondary school. So you can see this is the most recent week, is this hash to the 19th of September. And you can see in all of these ages, it has gone up significantly in a week. In the top two, 12 and 13-year-olds, it's gone down, 12 and 13, I mean. So this is 16 to 18-year-olds. Now, many of these children got vaccinated in the middle of August, towards the end of August, which is now, I think, starting to kick in alongside previous high rates. So I think here we can really see that actually vaccination does seem to be working to reduce cases once we've returned to education. An ONS infection survey today shows a very similar pattern. You can see cases are going down in all age groups, really strongly in young adults who are the most recently vaccinated and also had really high infections over the summer. But they're going up in school-age children and are quite high, almost 3% of secondary school kids right now are testing positive for COVID. I mean, that's 1 in 30, roughly. This is now the last section on the international picture. This is case rates in children in the Republic of Ireland up to the 18th of September. And where they're different from the UK is that they started vaccinating their 16 and 17-year-olds at the end of July, and their 12 to 15-year-olds in the middle of August. And what we see when their school started in September is the case rates in primary school children have gone up and gone up quite sharply. And in fact, the rates in primary school children, 400 per 100,000 per week, isn't that dissimilar from the rates we have right now in England. But in the secondary school children, there's been no back to school spike. So remember, in all of the UK home nations, the 10 to 14-year-old groups had the highest cases in the country. That's not the case in Ireland. They're coming down. They are a bit higher than adults, but there's no back to school spike. And this suggests to me pretty strongly that if you do vaccinate your teenagers before school starts, it does have an impact. And if we just look at the international perspective, these are all countries in Europe. They've all been vaccinating their 12 to 15s over the summer, some starting earlier than others. Now, the vertical axis here is different numbers in each country, so they don't compare across country. But these light colours, the under 15s, and in most of these countries, there's been no back to school spike. So there has been an island, but this is really driven, as we've just seen, by primary school children, but pretty much everywhere else there hasn't. Germany had a bigger one, but they've started vaccinating their teens the latest, right at the end of August. But places, say like Denmark, where they were doing it early August, have come down. So we can see again that these countries are managing to get cases down in secondary school kids, and most of them are also having masks in schools, bubbles in schools, testing in schools, and a lot of them are sending contacts of children who are contacts home as well. So just to summarize, vaccinations are continuing. The next big cohorts for vaccination are 12 to 15-year-olds and boosters, and hopefully we'll start seeing reported figures on that soon. Cases remain high in all nations, particularly Scotland and Wales, but they're coming down in Scotland, they're increasing in Wales and England, and at the moment they're kind of flattish in Northern Ireland. Hospitalizations are falling in England and Northern Ireland, and the recent increases are now flattening off in Scotland and Wales. But regardless, COVID does continue to be a considerable burden on the NHS. We are out of step with international countries when it comes to vaccinating children and mitigations in schools. So Wales and England are now seeing really large surges in cases in school-aged children. If the experience of Scotland is anything to go by, that might peak in a week or so, but only after a significant proportion of kids have been infected. There are some signs that infections in school-aged kids might be filtering through to their parents' generation. And from other countries, it seems likely that a vaccination campaign over the summer could have prevented the current surge in secondary school kids. And finally, I just wanted to give you a quick update on variants, which we've not heard much about. So there are new strains emerging around the world, some of which have quite worrying mutations, but nothing at the moment is out-competing Delta. So Delta is so transmissible that even if you get a new COVID strain that's more vaccine resistant, it can't cope with Delta, and it looks like it dies out. So that's actually kind of a silver lining to the Delta cloud, if you like. Delta itself is continuing to mutate. It has about over 15 different substrains now, but none of them seem to be markedly worse at the moment. So it's kind of people are watching it, but it's not like any of them at the moment anything to worry about. But it is still continuing to mutate, so that is still a potential to keep an eye on. But at the moment, there's nothing on the horizon that's particularly worrying, and that's it.
Okay, Christina, thank you very much for that update. Very detailed, very interesting. We're now going to go to Professor Stephen Riker, who's going to present the Independence Age Winter Plan. Stephen, over to you.
Okay, can you put the slides up? Thank you. Thanks for that. So, Christina has given you a very clear and a very powerful account of the situation that we are in, the high number of cases, the rising case rates, especially in children. And I'm going to be talking about what are we going to do about it. I'm going to talk about our Independence Age Winter Protection Plan. The plan, a 9-point plan, is on the web, and I'm not going to simply repeat it. You can all read it there. What I want to talk about are, if you like, 4 fundamental underlying principles which guide the plan and explain what goes into the plan. And those are act now, make systems that work, protection first, and act global. So let's go to the first one on the next slide, act now. Sometimes there is an almost uncanny sense of déjà vu. Many of you will remember the 21st of September 2020, last year, when SAGE met, and SAGE warned that as conditions get worse in the winter, as people move more indoors, as colleges come back, as people go back to work, as well as schools going back, there is a danger of cases rising and a real impact on the NHS. And they called for action. And we all remember that it took until November for the government to react. But by then, cases, hospitalizations, deaths had run so far out of control that we needed severe restrictions to deal with the pandemic. And so we had the non-Christmas, the on-off Christmas, the stop-go Christmas, and we had an awful winter and spring. And now this year, almost a year later, a year after the 21st of September 2020, it was in fact the 8th of September 2021, SAGE met again. And SAGE again pointed to the danger of a difficult winter and the need to take action, and to take action early. And the question is, will we repeat the mistake of last year? Will we wait too long? Will we allow things to get worse before we act? Will we, hopefully not, have the same non-Christmas and awful winter? And remember also that one of the first things that the World Health Organization said was, whatever you do, act early, get on top of the virus. And so what we're saying is that we need to act now, not wait and see, not wait until things are out of control, but use proportionate measures, more protections than restrictions, things that don't get in the way of our life, but things that keep us safe. So the first principle, as I say, is to act now. And the first difference between the Indy-SAGE plan and the government plan is we are saying, let's have action and let's have it now. Let's go on to the second principle. And the second principle is, in a sense, to reiterate, I'm sorry about this, but to reiterate things we've said throughout the pandemic. If you recall, to when our briefings would finish with David King, nearly always talking about the need to have a test and trace system that works, systems that work. So we, like the government, like everybody, is calling for a vaccination rollout, but centered on community engagement. If you look at the figures, and Christina has shown us the figures, there are a sizable number of people, especially under 30, or indeed under 40, who aren't vaccinated, 30 to 40%. But it's wrong to see that in terms of vaccine hesitancy or in terms of being anti-vax, because only about, well, less than 10% of those have got any doubts about the vaccine, are vaccine hesitant. They simply haven't got round to it. And therefore, we need to make it easier to get vaccinated. We need to have vaccine stations in schools and colleges and universities and workplaces and in communities. We need to make sure that people have paid time off to get vaccinated. And for those who do have doubts, we need to engage with them and talk to them and explain to them, not treat them for fools, not call them selfish, not alienate them. The very people we need to engage with disengage if we start blaming them. So we need to up vaccination, but through those simple and well-worn and well-tried methods of going to people rather than waiting for them to come to you and engaging with communities. Again, we need a test and trace system that works, that's rooted in local communities and local public health, where the contact tracers know their patch and can knock on people's doors if necessary. So again, there still is a need to have a test and trace system which works. And finally, it becomes ever more important that people who are infected do self-isolate. And still the question is, are they able to? Do they have the resources? Do they have the support? So again, we need systems that work because they go to people and they support people. The next principle. Very often in the public debate, there has been a conflation of COVID measures with COVID restrictions and COVID restrictions with lockdown. And so people say that whenever you talk about a measure, you're talking about lockdown, but we're not. And that's wrong. And in fact, it's not only wrong, it gets things precisely the wrong way round, because if you don't protect people, if you don't emphasize protection and people stopping getting infected, that you get high levels of infection, and so you have to impose restrictions. So protection stops you having to impose protections. So we argue, first of all, there needs to be clear and consistent messaging that infections matter. One of the real dangers is that government messaging in what it's doing and in the actions of ministers implies to people that infection really doesn't matter. And if infection doesn't matter, why should you do anything about it? So we need consistent messaging, and we also need clear and consistent information about how people can calculate the risks to themselves and how can we mitigate against them. But of course, it's one thing to explain to people why it matters and why, for instance, it's important to keep the windows open. It's quite another thing to have windows that open. If you don't have windows that open, whatever you know isn't going to help you very much. And therefore, one of the key things that we call for is a much greater emphasis, not on individuals, but on the environment, and making environments that are safe for all of us, and ensuring the public spaces we go into, whether those are schools or colleges, whether they're workplaces and bars and restaurants, whether they're large venues, nightclubs, football games, and so on, meet COVID standards. We don't want them to be closed. We want them to be open. But to be open, we want them to be safe. We want there to be clear standards. We want there to be certification. We want there to be clear and transparent information so that when you go to a restaurant, just like you see hygiene certificates, you can see a certificate indicating that this is COVID safe. And that's not only good for public health, it's also good for the economy, because if people are confident, they will go out to those bars and restaurants and venues. We also say in terms of protection that people should be enabled to work at home. One of the key figures, one of the key statistics in the transmission of disease is how many contacts you have. And contacts are going up. But they're not going up because people are socializing and partying more. They're going up because people are meeting more at work. And if you take away the increased socialization at work, there's no increase in the contact figures. So allowing people to work at home where they can and where they want to, enabling people to work in ways that protect them is critical. And yes, we also argue there should still be masks in crowded indoor spaces, especially those which are not well ventilated, well distanced, sufficiently hygienic. So a series of protections, and we focus on those protections, and those protections, if implemented, mean that it is far, far, far less likely we need to have restrictions. And finally, of the four principles, there's act global. We say it again and again. It has to be repeated again and again, because nothing is being done about it. None of us are safe until all of us are safe. That making sure that everybody in the world is vaccinated is critical to making sure that it doesn't come back to our shores. And equally, we need to act responsibly so we don't take it to other shores. It is still true that 80% of the vaccine has gone to the rich countries and 20% to the majority of the world, which is poor. That in Africa, only 3.5% of people are vaccinated, and in many countries, less than 1%. And just yesterday, Amnesty International came out with a coruscating report called A Double Dose of Inequality. And this is what they said. I think it's worth reading this because it's so powerful. Vaccine developers have monopolized intellectual property, blocked technology transfers, and lobbied aggressively against measures that would expand global manufacturing of these vaccines. Some companies, Pfizer, BioNTech, and Moderna, have so far delivered almost exclusively to rich countries, putting profit before access to health for all. Well, we argue there should be health for all, and health for all means vaccine patent waivers and technology transfer so that everybody in the world can produce enough vaccine for everybody, and we don't have to compete, and we no longer monopolize it in rich countries. I just want to finish in the final slide with one general comment. Whenever we talk about measures, people argue, what about the vaccine, as if we're ignoring the vaccine. Well, actually, the opposite is true. As many people point out, the thing about the vaccine advantage, if you like, is that now it is possible to control the pandemic with the vaccine and much milder measures than last year. We don't need the lockdowns of last year if we act sensibly and proportionately. And many countries around the world, and here's a partial list of Denmark and Israel and Italy and Portugal and Singapore, have shown that even with the Delta variant, the extremely transmissible, contagious Delta variant, it is possible to control the pandemic with vaccines and moderate protections. And our plan is based on precisely that. And the irony is that if you just have the vaccine and ignore those protections, then you don't do enough to get on top of the pandemic and you squander the advantage provided by vaccines. So yes, this year is different. And yes, this year our winter plan is different. And this year we don't need the restrictions we might have needed in the past, but we do need protections. And if we don't have those protections, the real danger is that the spectre of restrictions will come back. And that's the end.
Okay, Stephen, thank you very much indeed. We'll go to the press and public for questions now. Let's start with Nisha Nayak. Nisha, are you there?
Yes, I am. Hello, thank you.
Yeah, please go ahead with your question.
Okay, so I've got 11-and-a-half-year-old and a 9-year-old. The older one is in secondary school, the younger one is in primary school. With the vaccine rollout starting with 12 to 15-year-olds, clearly my older one is not eligible for the vaccine, but she will still be in a very large comprehensive school with so many infections. So why are the younger ones not included? I am aware that the approval is for 12 and over, but how will we tackle infections in this age group, most of year 7, that is, and also in terms of the basic mitigations like mask mandates or ventilation. I mean, why are schools not doing enough? I mean, I just feel like I'm sending my children into a very, very crazy, scary experiment. I would rather just vaccinate both of them without even any data available for the younger one, rather than send them in every day, not knowing what's going to happen.
Thank you, Nisha. There's quite a few questions there. So can I just repeat maybe the ones I think which are relevant to this discussion? The questions are, when will Nisha's children, who are 11 and 9, be eligible for their first COVID vaccine? Do we have any details or information or insights on that? Who would like to tackle that? Yes, Anthony.
Thanks very much, Nisha. It's a really important and good question. Just on the vaccination front, Pfizer this week published a trial suggesting that it was quite safe to give children aged 5 to 12 the vaccine. And I think Dina may know more about this, but I think some countries are already considering it and maybe moving there quite fast. And I sympathize with that view. Personally, I think if all the safety standards are met, that it makes sense to vaccinate 5-year-olds and over. The masks one is a little bit more tricky, and Susan and others may have other views, but my view is that the older children in that age group should be able to handle masks, particularly moving around schools and in classrooms that are perhaps not as well ventilated as they should be. I think once you get below 7 years of age, maybe it's becoming a little bit more tricky to sustain that and uncomfortable for the children and the like. But I would leave that up to the teachers to decide what they do, actually.
Susan, do you have any thoughts on the masks for schools?
Well, when secondary school children were mandated to wear masks, there was no big protest against that. The overwhelming majority of secondary school children were wearing them without complaint. I think one of the things we haven't done enough of in the UK is look at the rest of the world and what the rest of the world doing. And there's many other countries where all school children wear face masks. And given we know that face masks do reduce transmission, I think we should be looking at the evidence of the experience of younger children wearing it in other countries, learn from their experience, and on the basis of that, consider introducing it, as always, with consultation with children, with parents, with teachers, so that there's a process of bringing new measures in rather than just one day announcing it.
Thank you, Susan. Let's go to the next question. This is from Susie Ray. Susie, are you there?
Hi.
Hello.
I wondered, could you explain why the COVID numbers in Northern Ireland are static, if not declining, after schools return? We kind of expected a sharp rise in numbers, like in Scotland. Is this the calm before the storm, or does it reflect the 2-month COVID cycle that I've been reading about?
Okay, good question. Christina, yes, you're a perfect person to answer this.
So I think what we're seeing is that you are seeing increases in children, but that's being offset in overall case numbers by actually, I think now, really steep declines in young adults, which I think is due partly to really high cases over the summer and vaccination really kicking in. A lot of 20-somethings had their second dose in August. And so that's kind of hiding the fact that it's quite a different picture depending on what age you are and whether you're vaccinated or not vaccinated. And I think where Scotland was a bit different is because they went back a couple of weeks earlier, they had less vaccination. I mean, I think that has really made a difference in the fact that we did have a little bit more vaccination in young adults by the time we started school. Now, the question is the really high cases in kids going to feed through to their parents and potentially their grandparents? And that will kind of become clear over the next month or so.
Okay, thank you very much. That's nice and clear. Okay, next question is from Emma Kelly, and I'm going to read this one out. Emma would like to ask opinions on why the symptoms for testing have never been updated when we know that Delta certainly presents differently from the initial virus strain. Also, what do independent SAGE think about the potential impact of this on rising cases? So this is a good question maybe for some of the virologists on the panel. Perhaps, Dean, and you could answer the first bit about why do you think that the symptoms for testing have never been updated and we know that Delta presents differently?
Well, I don't know. I'm sorry to say. The thinking around symptoms before I let others. I'm sure Helen would have a view on this as well. But just sort of something about the basis of selecting symptoms. Yes, there are a large array of symptoms that could be associated and are associated with COVID. I think the question is why identify specific symptoms and what symptoms are particularly associated with COVID versus associated with other infections going around, for instance, or other causes. And so it's that balance. Now, the other issue is why there's a list of symptoms. And of course, if the purpose of a list of symptoms is to stimulate someone to go and get tested, then of course, we want a wide array. There's no cost to people going and getting tested, even if they're testing negative, if they're aware of that. But for epidemiological purposes, of course, one may want to limit the number of symptoms to symptoms that are particularly specific to COVID. So I think there's a balance, and it's to do with the reasons. But my sense is there's always been a limitation. And since the Zoe app first identified a much bigger, larger range of symptoms at that stage, I think there should have been a response, and there hasn't been a response. But I'd welcome Helen's views as well, who may be seeing people with an array of symptoms.
Helen, do go ahead if you've got something to add. And also the second part of that question, in case you had anything to say on it, was whether the panel thinks that that the lack of change of symptom reporting has maybe had an impact on the rising number of cases. But go ahead, Helen.
I think it is really quite a problem that we haven't had a change of definition of symptoms, because we know from Tim Spector's and the Zoe app work that actually the continuous cough and the loss of taste and smell are actually not as common with the Delta variant as they might have been with the earlier variants. And they also often come later. And that's one of the issues that people actually now often present with sore throats and runny noses, which are quite non-specific because they're also symptoms of other things, but they are often the early symptoms and sometimes the only symptoms of Delta, particularly in people who have been vaccinated. So I can completely understand that there may be people who don't want to confuse people by changing too often what the symptoms might be. But the fact that we haven't changed at all means that, and we haven't really got that message out to people. I do have a lot of people saying, no, I don't have a continuous cough. I haven't lost my sense of smell. I don't think I've got COVID. When you persuade them to go and get a test, they do have COVID, because it is a much wider range of symptoms than are currently being advertised. Now, why they haven't changed, I find slightly mystifying, because if we want everybody who might have COVID to have a test so we know how many people have COVID and so we can stop it spreading further, then we need to be testing everyone who might have it.
Stephen.
And we're not.
Thank you, Helen. Stephen.
Yeah. So, I mean, the first point, of course, is not only do we need people to get tested, we need people to get tested early, because if you leave it for too long, then you can be spreading infections. So those two things are critical. And at the moment, we're doing some research. We have a research project looking at precisely this question. What determines how early or late people get tested? And in many ways, it's a rather nice reflection of some of the work that that Susan has done on behavior and behavior change and the factors that are involved. So the first thing you need, of course, is clear information. To get tested on symptoms, obviously, you need to know what those symptoms are. And if you don't know what those symptoms are, you're not going to get tested. The second thing is, if you like, just the practicality. You're not going to get tested if you can't afford to test positive. If testing positive, meaning self-isolation, is something which would cost you too much, or you simply can't arrange it practically in terms of accommodation. And that's a second factor that comes over very, very clearly in our research, that if people think they're going to have more support, they get tested sooner, earlier, more quickly. And the third factor, and I think this is a rather interesting one, is, of course, you've got to have the motivation. You've got to care about it. Now, when people think about their personal risk, many people think their personal risk is low, and so they don't necessarily feel it's that urgent to get tested. When they think in communal terms, when they think in terms of the impact of infection, not just on themselves, but others and more vulnerable people, actually what you find is that they get tested more quickly and earlier. And it goes back to a point, again, we've been making throughout, that at the start of this pandemic, one of the things we did is we had a sense of community, and we created a sense of community. And all the research showed that when you looked at the factors that led to adherence, they were more a concern that everybody comes out of this well than that one does as an individual. It was about we, not I. And in recent months, the emphasis has shifted back. It's about the person. It's about personal responsibility. It's about what happens to you. And I think we need much more messaging, which goes back to what worked before, which is a sense that this is about a community. You get tested, you wear a mask to protect everyone, to make it safe for everyone to be able to go out, that the opening of our society is an inclusive reopening. So I think the issue of testing raises all those issues and points to a number of critical things that need to be done to keep us safe and to get on top of the pandemic.
Thank you very much, Stephen. Okay, let's move on to the next question from Simone Todd. Simone, over to you.
Hi. I've done all I can to protect my family using masks, vaccination, being outdoors with others as much as possible, and my children in primary school. I've noticed that most parents I speak to are increasingly resigned to their children catching COVID. And this feeling of losing control of children's health and with few choices is becoming more common, especially because I think recently track and trace don't seem to be interested in school cases. So continuing high infections in school-aged children could be catastrophic for the potential number of child hospitalizations, long COVID sufferers, absence in education, etc., and vulnerable grandparents and family. With the current government stance of letting this rip and the limited action parents can take to prevent child infections, it feels inevitable our children will catch COVID. Should we continue to protect and keep reducing viral load so that when our children catch this, the impact is lower? Or is that a false assumption? I'm just a layperson, so I don't know the technicalities of that.
Is there, so the end of the question there was just, is there a merit in trying to reduce viral load? Who would like to sort of tackle that question? It's quite a technical one in some respects. Yeah, Dean.
Thanks, Simona. I'll just make a little sort of comment on a really important question. You touched on a number of things, but it is clear, and it's really unfortunate that the sort of narrative of senior medical leaders and government at the moment, whilst not saying we want to let this rip, they are in effect saying that by, for instance, the CMO, Chris Whitty, saying we should expect all children to get the infection. That in effect is saying exactly as you say, and you've outlined very coherently and clearly what the cost is of that to children, to education, and to parents, and so on. So, I mean, I think I can express our view as a collective group in Independent Sage. We do support limiting as much as possible infection in children through a range of ways. We've touched on vaccinations, but clearly about keeping schools safe, better ventilation, and so on. Just touching on your last question, I'm not quite sure I understood, but with regard to reducing viral load, I don't know whether you meant within an infected individual, child, or actually at a population level, just generally reducing the amount of virus around. Is that what you meant?
Yes, more the latter. So their immediate surroundings,
yes,
and keeping them ventilated, the surroundings ventilated. Yes,
absolutely. No, and that just goes along with our view that it's really essential. The Christina's data, she showed that is where infections are going. We're seeing a very much more rapid than I thought impact of a vaccination of older adolescents and teenagers. So and it's inevitable that younger children will at some point become eligible for vaccines, but it's just shameful that it's taken so long. But I'm sure others have contributions to make to your question.
Thank you, Dean. And Zubaida, you wanted to say something?
Well, I have to say, Simone, I empathise with you as a parent. I think it is really terrifying to completely lose control over your children's health right now, particularly because the only options available to us right now is vaccination or infection. And that is those are appalling choices in the sense that there are alternatives. And that's why, of course, Stephen, at the beginning, Professor Stephen Riker, when he presented our winter plan, showed us that we don't need to have options where it's either vaccine or nothing. We can have a vaccine plus approach where we still carry out lots of mitigations that help us control the amount of virus in the air. And so I think it is really dismaying what little the government are doing in schools. It's dismaying. They've removed all the mitigations and they've left the responsibility up to us, because there's only so much that we can do. There's only so much that head teachers can do. But I think everything we can do will matter. What directors of public health do as well matters. And it's quite interesting recently that Cumbria's County Council's Department of Cumbria's County Council Director of Health recently advised that siblings of children who test positive should in fact stay at home, should in fact take PCR 3 to 5 days later, because they could still be positive and they should self-isolate during that time. Now that's going against what the government is saying, but we know that that's good advice and that's what should be happening. So I think it's great. I think it's great what you're doing, and we're there with you.
Thank you, Zubaida. Christina, did you want to add something?
Just a really quick thing is that the recent ONS study on long COVID showed that for people who had a higher viral load in their initial PCR test, did seem to get long COVID more often. So it does kind of suggest that there might be benefit into if you get infected of, if you're wearing a mask, if it's well ventilated, and it might reduce the impact of the severity of the disease. Now that is just an association, but
we can't test that yet.
I thought it was relevant.
Thank you.
Okay, thank you, and Simone, thank you very much for your question. It's now 2:30, so we're going to have to wrap up, I'm afraid, there. Thank you to Professor Riker for presenting us with the winter report and Professor Christina Pagel for the latest numbers. You can read that winter report on the Independent Sage website, along with all of the group's other documents. So see you next week, and do tune in. And until then, be safe. Bye-bye.
Bye.